Hi, everyone. Thank you for joining us today. We do still have a few people joining in, but I will go ahead and start our intro slides because we have a lot of information to cover today. So my name is Kayla Cole. I work at Qualidigm, and today we are working with several presenters to present a webinar on safe sleep and breastfeeding, some helpful messaging and tips. We have Kara, Kelly, and Alan all joining us today, and we're excited to have them. But before we launch into the material for today, we want to cover a few webinar notes. You are in listen-only mode, so we ask that you use the Q&A function to ask questions or make comments. You can enter questions throughout. You don't have to wait till the end to enter those into the Q&A. You can do that throughout the session, and we will save time for questions at the end. Your video screen size and location is adjustable, so you can actually move around that box where you see the video right now. And if you are joining by phone or if you're with others on the same computer, which probably isn't as relevant right now, but usually is, we just ask that you either enter your information into the chat window, which means your name and your email, or you can email it to Mary at mmilam@qualidigm.org. We'll just need that information for attendance records for the CME. We do want to thank both the Hannaford Foundation and the state of Maine for providing time and funding for this webinar. And just a few notes about Qualidigm. Most of you might have noticed before as Maine Quality Counts, we did merge with a company out of Connecticut named Qualidigm. So we have multiple offices across New England, and we focus on quality improvement initiatives like this one. As I mentioned earlier, we are going to have CME available for today. So today's speakers do not have any relevant financial relationships with the manufacturers of any commercial products and/or provider of commercial services discussed in the CME activity. It is available for participants who have signed into the live webinar. So again, that's why if you could type your names and emails into the chat box or email your information to Mary if you've joined by phone, that is helpful for us for our attendance records. Once the webinar is ended, you should get a pop-up screen that actually gives you the survey that you need to take to get your CME. Sometimes it does not work, so we will also send that link in the follow-up email. So don't worry if it doesn't pop up at the end. We'll make sure that everybody that was on today's webinar gets that link in the follow-up email. We'll also put it in the chat box. You'll just need to copy and paste it though if we do put it in the chat box. It doesn't allow us to do a clickable link. So getting into today's speakers, like I mentioned, we do have 3 speakers today. So the first speaker I'll introduce is Kara. Kara has been an international board-certified lactation consultant since 2009. She has worked as a home visitor, postpartum doula, childbirth educator, childbirth education and lactation services program manager, and breastfeeding specialist for Maine CDC's 6 for Me initiative. She currently teaches prenatal classes and facilitates the weekly breastfeeding group for Maine Medical Center and is the breastfeeding consultant for Maine's Perinatal Outreach and Education Program. Kara also sits on the Perinatal Quality Collaborative for Maine Steering Committee. We're thankful for her time on that. She is passionate about providing education, support, and advocacy for women and new families. She lives in Freeport with her husband and 2 young boys. We also have Kelley joining us today. I know most of you know Kelley, but just a fresh reminder for those that might not. Kelley Bowden is the Perinatal Outreach Nurse Coordinator for the state of Maine. After graduating from the University of Southern Maine with her bachelor's degree in nursing, she joined the Maine Medical Center NICU staff. Kelley then went on to earn a certificate from Georgetown University as a neonatal nurse practitioner. After working in the NICU for 18 years, she left to become a chart abstractor for the Maine Birth Defects Program and assumed the outreach position in 2004. Kelley completed her master's degree in nursing at USM in 2005. For the past 10 years, infant safe sleep has been a priority of Kelley's. Most of you are very familiar with her work and the Snuggle Me guidelines that she's also worked on. She has partnered with hospital and community-based providers to assess infant unsafe sleep deaths and to educate those who are working with families on best practices to help eliminate infant unsafe sleep deaths. And then we are also being joined by Alan today. So Dr. Picarillo is a neonatologist at the Barbara Bush Children's Hospital Level 4 NICU and is involved in the creation, implementation, and data analysis of quality improvement efforts in newborn medicine. He is a member of the Neonatal Leadership Structure for the Northern New England Perinatal Quality Improvement Network, NEPQUIN, and Maine Perinatal Collaborative, the PQC for me. His areas of interest include implementation of lean methodology for quality improvement projects, the introduction of quality improvement measures to clinicians, and perinatal quality collaboratives. Previous work experience includes co-director for the Massachusetts Neonatal Quality Improvement Collaborative, executive leadership of Virginia Perinatal Quality Collaborative, chief of neonatology at UMass Memorial Healthcare, and medical director of Level 3 NICU at the Henrico Doctors Hospital in Richmond, Virginia. He also had a corporate position of director of clinical quality for Women's and Children's Service line for Envision Healthcare. In addition to all he already does, he's also national faculty for Vermont Oxford Network and has been involved in advocacy at the state and national level for NAS infants. He also has much experience teaching newborn resuscitation, both in the United States and abroad. He has served on the AAP Steering Committee for Helping Babies Survive program and has introduced and facilitated the instruction of Helping Babies Breathe curriculum to greater than 400 healthcare providers in Monrovia, Liberia. He has also been involved in teaching newborn medicine topics in resource-poor areas such as Liberia, Haiti, and Ecuador. So as you can see, we have an all-star lineup today, as we usually do, but we thank Kelley, Alan, and Kara for their time in joining us today. I know schedules have been a little bit different with everything going on, so we appreciate you joining us and all the time and effort you've put into this presentation. And Kara, I will turn it over to you, but I will help you out and confirm on your screen share and all of that if you need.
Great. How is that?
Perfect. We can see
Excellent. Hi, everyone. I'm Kara Kaikini. Glad to be here with you today. I realize that I'm wearing the same dress that I was wearing in my bio photo. Different earrings, though. It's a comfortable dress. I'm happy to be here with you today to talk about safe sleep and breastfeeding. Our objectives for today are to review the AAP SIDS policy statement and the ABM bed sharing and breastfeeding protocol, to understand the challenges in meeting safe sleep recommendations in the context of exclusive breastfeeding, and to receive guidance and resources, including messaging around how to help families exclusively breastfeeding create plans for safe sleep. So you are probably familiar with the American Academy of Pediatrics SIDS policy statement. The statement is based on meta-analyses showing the effect of breastfeeding is stronger when it is exclusive, but any duration after 2 months is associated with a significant reduction in SID. So they are absolutely highlighting breastfeeding as a recommendation to reducing the incidence of SIDS or the risk. The AAP also acknowledges that parents frequently fall asleep while feeding their infants, and that evidence shows it is less dangerous to fall asleep with a baby in a bed than on a sofa or armchair. They note that a large percentage of infants who die of SIDS are found with their head covered by bedding, so no pillows, sheets, blankets, or any other items that could obstruct infant breathing or cause overheating should be in the bed. And because there is evidence that the risk of bed sharing is higher with longer duration, if the parent falls asleep while feeding the baby in bed, the baby should be placed back on a separate sleep surface as soon as the parent awakens. So that's a pattern that we're going to hear. They also outline the riskiest times and ways to bed share. If an adult smokes or a mom smoked during pregnancy, that elevates the risk of bed sharing. If the adult is impaired by alcohol, medications, or substances, any sleeping on a soft surface or soft bedding, if the baby sleeps with a non-parent, and if the baby is younger than 4 months. So they recognize that there's an increased risk of SIDS, even for breastfed infants, when bed sharing is happening when the infant is younger than 4 months. So it appears to be a vulnerable time. So if parents choose to feed their infants younger than 4 months in bed, they should be especially vigilant to not fall asleep. They also reference breastfeeding when they're talking about pacifier use, and that it should be introduced once breastfeeding is firmly established. And I like to define breastfeeding as established by saying that the baby is effectively receiving enough milk and that the mom is comfortable and not in pain. They also mentioned that safe campaigns should include strategies to increase breastfeeding in addition to decreasing bed sharing and eliminating tobacco smoke exposure, which is one of the biggest risk factors of SIDS. Maine, as you know, launched a Safe Sleep campaign last year, which is simple, thorough, and straightforward. Check it out if you haven't checked it out already at safesleepforme.org. And of these recommendations, the one that is often most challenging for breastfeeding moms is the alone in their crib recommendation, that first one. Breastfeeding mothers comprise the largest group of bed sharers. And research has shown that there are some benefits to the baby in terms of quantity and duration of breastfeeding, and some benefits to the breastfeeding mother in terms of duration of sleep, as reasons for why we see that. So due to the fact that most bed sharers are breastfeeding mothers, the Academy of Breastfeeding Medicine recently revised their bed sharing and breastfeeding protocol. And this protocol shares that existing evidence does not support the conclusion that bed sharing among breastfeeding infants causes sudden infant death syndrome in the absence of known hazards. Again, they say accidental suffocation death is extremely rare among bed sharing breastfeeding infants in the absence of hazardous circumstances and must be weighed against the consequences of separate sleep. They state that there are consequences to breastfeeding with separate sleep, even with room sharing, that include the risk of early weaning, the risk of compromise to milk supply from less frequent nighttime feeding, and unintentional bed sharing. And in Maine, we know that the low milk supply is one of the #1 reasons women stop breastfeeding. The last PRAM survey in Maine showed this as the top reason for no longer breastfeeding at the time of the survey. This is in line with what I hear on a regular basis from moms about their concerns about their milk supply and ability to satisfy their babies, often particularly in the evening. So the ABM protocol explains how breast sleeping can be protective against SIDS by allowing for more microarousals and less time in deep sleep. And they cite research done in the Mother-Baby Behavioral Sleep Lab at the University of Notre Dame, showing that sleeping in the C position can be a safe position where mom is less likely to position baby on or near a pillow. This may be something that you've seen before. It's often not part of education. It is part of the Academy of Breastfeeding Medicine protocol, and it's something that is good to be aware of. They state that the behavior and physiology of breast sleeping dyads may be different than that of bed sharing non-breastfeeding dyads, suggesting that the safety assessments for bed sharing with breastfeeding versus feeding human milk substitutes likely require different approaches. And the ABM statement conflicts with other organization statements and has been considered controversial. First Candle is dedicated to reducing the rates of sudden infant death syndrome and preventatal stillbirths. They responded to this statement saying, "We support breastfeeding, which is associated with a reduced risk of SIDS, and although we do not agree that bed sharing, even if it may promote breastfeeding, is worth the risk of SIDS, providing the cited hazards are not present. We do agree with the ABM on open and honest dialogue between parents and providers." And ultimately, the ABM protocol does not recommend that every mother or every breastfeeding mother bed share with her baby. It recognizes that bed sharing can certainly be especially dangerous in certain situations, particularly if the baby was born preterm, if the baby was exposed to prenatal tobacco exposure, if they live with smokers or people who consume alcohol or drugs. And they suggest that all families should be counseled about safe sleep, including discussion with open-ended questions, and that information and counseling about safe bed sharing should be offered. They say, quote, "One must assume that parents may bed share anyway, even if unintentionally." So they suggest that information is shared in case this happens. They also recommend having non-judgmental conversations and acknowledge the context in which they may be making these decisions, that parents will be making these decisions. They say that ending stigma around bed sharing and educating all parents about safe bed sharing have the potential to reduce infant deaths. Bed sharing evolved from innate human biological and behavioral mechanisms. It is not a singular, discrete, or coherent practice, but is composed of a diverse range of behaviors, some of which may carry risks, making it particularly important to discuss bed sharing safety. They also recommend a few public policy changes, including increasing tobacco prices, ending racial bias in the healthcare system that undermines breastfeeding, and advocating for the allocation of research funding and resources focusing on the risk factors for sleep-related death that are related to evidence-based level of risk. Some might also suggest public policy to help parents be less exhausted, like paid leave or affordable quality childcare as well. Instead of anti-bed sharing approaches, some recommend educating women about safe bed sharing practices, and that the advice to completely avoid it has the potential to undermine breastfeeding and may actually increase the risk of sleeping in unsafe environments like sofas. They say that despite campaigns to decrease bed sharing, reported bed sharing has actually increased in the US in recent years. And they say that a simple, clear, direct approach that includes anti-bed sharing messages can lead to stigmatization that can prohibit honest discussion among parents and health professionals. Some of you may have seen this campaign before, and this was in Milwaukee maybe 10 years ago, with a baby laying next to a knife and equating bed sharing to having your baby sleep next to a knife. And there is some research that shows that people avoid or resist information if it makes them feel bad, if it obligates them to do something they don't want to do. Like a lot of parents want to snuggle with their baby at night. They also want to do the easiest thing they can to get some sleep. They might also avoid it or resist it if it threatens their identity, their values, or their worldview. And maybe this is something that other people in their communities do or don't do. So it's based on sociology research that has also found that people avoid information that makes them feel sad, fearful, or guilty when there isn't a way to resolve those feelings. And it's also not entirely about lack of education, why some families might not be following these recommendations. You may recognize this device. It's the Fisher-Price Rock and Play. It was recalled last year. And it's a device that has been highly recommended and sworn by parents for years, despite them not being recommended by organizations like the AAP. And this article speaks to the fact that parents use this anyway because they are desperate. Why? Well, they often have to return to work early. They don't have, and they might not have paid leave. They have a lack of postpartum support. They may be single parents. They may be experiencing homelessness, substance use, violence, incarceration, etc. And I think the biggest ones that we often see are parent fatigue and infant fussiness. New Zealand has a sudden infant death prevention program that includes a recommendation to encourage and support exclusive breastfeeding and gentle handling of the baby. And when I first saw that, I thought, oh, that's different. It's not terms that we've heard in safe sleep campaigns, but I think it's actually really important because it's crucial that we address the frustrations parents feel when the baby does not fall asleep or stay asleep alone on their back in a crib. The potential for shaken baby syndrome and the introduction of formula overfeeding is increased when parents are exhausted and desperate for their baby to sleep. And their frustration when their babies won't do what they're supposed to do, especially when it's made to appear simple. So I posted a brief survey about parents' experiences meeting safe sleep recommendations to about 5 or 6 different mom groups on Facebook and received 56 responses within a few days. 61% said they always or usually are able or were able to meet safe sleep recommendations for both naps and nighttime, and I cited the ABCs specifically. 34% said sometimes or rarely. There were a couple that responded other, and their comments were that they said always, unless I accidentally fell asleep nursing in the middle of the night. One person said 0 to 6 months in the crib on back, 6 to 12 months in my bed, and 12 to 24 months in the crib. When asked what the biggest barriers to meeting safe sleep recommendations were, these were the most popular words used. 17 responses used the terms needing sleep, exhaustion, fatigue, tired, sleep deprivation. 17 referred to their baby not sleeping or being a difficult sleeper. 9 people mentioned breastfeeding. And a couple of people referred to the grandparents' practices as barriers. There were a few responses that said that there were no barriers, or I appreciate the safe sleeping recommendations and haven't had trouble maintaining them. I'm not going to go through all of the comments that were left, since there were 56 of them for each of the questions I asked, but I am going to go through a few here just to give some of that parent's voice to this topic. Someone said, my first child was a very difficult sleeper, and the only way I could get any sleep was to have him in bed with me. Since that was my norm, it was what I opted to do with my second child also. I had suffered from severe postpartum adjustment with my first baby, knew that sleep, or anxiety rather, and knew that sleep was essential for my mental health. Another person said, we were doing well with having our baby sleep in his bassinet until we hit the 4-month sleep regression. After several nights of frustration, trying to put him down 4 to 5 times after nursing before him staying asleep and little sleep, we started bed sharing. It's the only way we've been getting sleep. Looking back, we also had difficulty the first couple of weeks. He would only sleep on my chest, but I was too afraid to let him sleep in bed with us. Needless to say, I did not get much sleep in the first couple of weeks. Another person said the time period when they just wouldn't go to sleep was the barrier they referenced. There were some nights when my husband wore a child in a baby carrier for a couple of hours because she just wouldn't settle down in the bassinet. I recall one night when one of the babies just wouldn't settle down and I was too tired to keep walking her up and down the hall, so I put her in the bouncy seat. I knew I shouldn't, but I desperately needed to lie down. So parent exhaustion would also be a barrier. Someone said breastfeeding on demand with no help. Another said needing to be able to sleep to function at work / ease of bed sharing. Another person said I did meet safe sleep requirements, and she references what's called the Safe Sleep 7, which comes from, I believe, the La Leche League, International La Leche League. And she cited 1, no smoke, 2, sober parents, 3, baby at breast, 4, healthy baby on their back, in this case typically on his side, 5, lightly dressed, 6, relatively firm mattress, and 7, covers off or away from his head. When asked, what advice would you give a new mom trying to meet safe sleep guidelines while breastfeeding? These are some of the responses. Every family is different and will be comfortable with varying scenarios. There's no one-size-fits-all solution. If there was, we'd all do that. Consistency is key. If you nurse lying down, make sure your partner is there to spot you to avoid falling asleep. Don't breastfeed in bed, particularly at night. Find a way to occupy your brain during night feedings, like a book, podcast, TV show, etc. Honestly, to research safe co-sleeping recommendations, it is so often done out of desperation and in fear / shame that it stays hidden and there is no support and not a lot of resources. Keep the bassinet right by the bed or get a co-sleeper. And honestly, I think I stressed so much about safe sleep that it resulted in baby and me getting less sleep. I felt like I could never let him sleep on me, etc. I wish I would have been more flexible, knowing that safe sleep is the goal, but also it's okay to break the rules sometime. Try your best, but it's pretty much impossible when you are sleep deprived. Use your phone to keep you awake. I played a game for a while. That helped when he was only waking up 2 to 3 times per night, not so much with 6 to 10 times per night. Get the baby to fall asleep without nursing to sleep. I eventually 11 months and it helped a little bit, usually 3 wake-ups, until he started teething more. During teething, it was back to 6+ times a night. I think this one seems to be a little of the more extreme experience that I hear about on a regular basis. But it also shows how much things change over that first year too. Be patient. Split the overnight into shifts so that each parent gets some protected sleep. When baby is old enough, 5 months, teach independent sleep skills using a method you are comfortable with. I asked if anyone had any other thoughts, and this is one. A one-size-fits-all approach like the ABCs is so problematic and will increase the likelihood of dangerous sleeping, as it isn't realistic for so many parents. Without education and a myriad of safe sleeping options, people will just do what works, but might be much less safe. For example, bed sharing can be done safely, but if there's no education on how to do that, and an exhausted parent brings a baby to bed, they may not do it safely. They also may end up falling asleep with a baby on the couch, thinking bed sharing is unsafe, when the couch is actually so much less safe. There are so many reasons that strict teaching of ABCs can actually be dangerous. Another person said, it would be nice for safe sleep practices to be presented as less black and white and strategies for troubleshooting problems to be offered. For example, moms should know that if they're exhausted and falling asleep while nursing, it's safer to be lying in bed than on a recliner or couch. just a couple more here. I never thought I'd co-sleep. It's horribly dangerous, right? Until I had my 4th child, and he would not sleep more than 30 to 45 minutes on his own, even in our room. I researched how to safely co-sleep and now regularly bring him into bed with me when he wakes for the first time to nurse at night. I felt more comfortable doing that because he was older, 6 months, and we met the safe sleep 7. I wish healthcare providers would talk more about how to mitigate risk while bed sharing, since so many newborns simply will not sleep on their own for many weeks. Parents find themselves bed sharing without thinking through how to make it safer. Co-parent sleeps elsewhere, no bedding, etc., or accidentally falling asleep on the couch or recliner while holding a baby because they think bed sharing is dangerous. I would love to see more nuanced conversation about mitigating risk in different scenarios. The Journal of Midwifery and Women's Health actually published a study in 2018 looking at women who bed share more frequently at 14 weeks postpartum subsequently report longer durations of breastfeeding. And in their discussion, they say, regardless of infant feeding method, given the frequency of bed sharing reported by women in this and other samples, clinicians encountering pregnant and postpartum women should teach safe bed sharing practices. So education on safe bed sharing may be considered a risk mediation strategy. This parent education, which is available on the National Institute of Child Health and Human Development website. If you haven't been there, please go to it. They have really great information, and it is one of the resources cited at the end. They provide education on safe sleep, like keeping baby in the mom's room close to the bed, but on a separate sleep surface, and offer some solutions and risk mediation. It doesn't specifically share how to sleep safely with your baby, but it does share how to make the bed as safe as possible if you bring your baby into bed for feeding in case you fall asleep. It also recognizes mom's fatigue and says, be mindful of how tired you are. Ask someone to stay with you while you're breastfeeding to keep you awake. And so offering more suggestions for how to manage nighttime feeding when so tired would be a beneficial addition to education about safe sleep. We have to do more than just say, don't bring your baby into bed with you or don't fall asleep with your baby, since there are often bigger factors in play that make this much easier said than done. NIH Safe to Sleep has this interactive room that is also worth taking a look at. It's really neat. If you click on the bed, it says breastfeed to reduce the risk of SIDS. Breastfeeding has health benefits for mother and baby. If you feed baby in your bed, remove all bedding and soft items. If you fall asleep, place the baby back in a separate sleep area when you wake up. So in terms of having that nuanced conversation, conversations do help mothers make their voices heard through sharing their experiences and their opinions, and it helps to teach us to better understand what they need and how to then best support or educate them. So first, it's always good to remember and adjust your underlying assumptions. So our role is to be supportive and not authoritative, since that can often shut some people down, especially if they're on the fence about something. Be passive and listen, obviously needing to hear what moms are saying. And use open-ended, probing questions to inspire a two-way conversation. Often our education is one way, and the two-way conversation is really what is going to be most helpful with topics like this. When providing education, share the whys and not just the whats. So rather than just telling them what they need to do, explain why it matters and why it relates to the goals and questions that they may have expressed. Develop a plan and include the mom in that plan. So how is she going to be meeting these recommendations? How is she going to be breastfeeding? And including them in that plan gives them a sense of control and makes it more likely for them to succeed. And then ask yourself too, where do I fit in this family's breastfeeding journey or this parent's newborn parenting journey? What is my role here? And even if you only have limited time with the family, since I think a lot of you only have a limited time with them in the hospital in particular, you can at least begin to uncover their questions and concerns and then plan to hand off to the person who will continue that conversation. There's so many topics you're educating on, so I know that this is just one of many. But it might be worth documenting what questions or concerns they have for the next people that they'll be seeing. How the conversation happens is important too. So these conversations need to be judgment-free, just like all of the guidelines suggest. Without empathy and acknowledgement of any other bigger barriers that they have, mothers often can disengage and feel less than supported or empowered. One way of offering them that empowerment and support is to use motivational interviewing. We can learn a lot from them, from that strategy. So change or making a different choice is most effective and most sustainable when individuals choose to make the change because they've realized it supports their goals. One motivational interviewing technique is called the love technique. I like this, it's easy to remember. And that's, again, to listen to what the families are saying, ask the open-ended questions. I have some coming up on the next slide. Validate their feelings, reminder that she's not alone. She's not the only one that might be having a tough time with this. And provide education that addresses their specific concerns. So some examples of open-ended questions could be, what are your plans for where your baby will sleep? What does that sleep area look like? And so these open-ended questions might be, you can be providing the safe sleep education when asking these questions. Again, this is a two-way conversation, not just a one-way, here's the information, this is what you should do. But asking these questions is really a great way to start that conversation. You could ask, what do you know about safe sleep recommendations? Instead of just telling them what they are, ask them what they already know, and ask, how do you feel about those? What are your biggest concerns about being able to meet those? They might not have any concerns. They might say, yep, they sound good. And maybe ask, how do you plan to get sleep throughout the day and night? Since we know they're going to be tired and that these recommendations are going to be harder when they're extra tired. So for those of you who are providing this information during the postpartum stay, this is considered anticipatory guidance, right? And that is really crucial when it comes to this topic. Same thing with breastfeeding. So think about a mom who had expectations about breastfeeding, that it would be really easy and all she had to do was put the baby to her breast and the baby would breastfeed. So the recommendation is breastfeed, and just it's really simple. That's the best thing to do. It's really simple. Then how does she feel when it isn't that simple, when it's not easy and her baby wants to nurse every hour? She will probably be feeling really frustrated and also maybe confused. Like, I didn't think this was going to be hard. I thought breastfeeding was going to be really easy. I think we've all encountered those families, those parents. So to ease that frustration, we often give her some tips and suggestions for how to make breastfeeding easier and to normalize the baby's cluster feeding too. So I would recommend that you consider the same thing for sleep. And if a mom isn't prepared for the possibility that her baby won't just fall asleep or stay asleep when placed in a separate space on her back, then she might be surprised and frustrated. And we want to think about those times when they get really frustrated. What are they going to do? How might they react? What coping skills do they have? And what tips or suggestions can we offer to make it easier? And how can we normalize that her baby's behavior is normal? And not every baby does respond well to the recommendations. So doing this before it happens is even better than addressing it during a pediatric phone call or visit. So what else can we do? If we empathize with their challenges and discuss challenges or discuss solutions, this should always include risk mediation. And we can give them practical suggestions to help make the safe choice easier in those challenging moments. So suggestions for not falling asleep while nursing in particular might be to read a book, text your mom friends that are awake too. I hear this a lot. Moms who send a friend a text at 3 a.m. and they get a response right back because they are also up nursing. And those are the loneliest hours, I'd say, from 1 to 5 a.m. in the morning for breastfeeding moms. And to not feel alone during that time, I think can be really, really helpful. And to be validated if they're like, my baby won't stay asleep in his crib on his back, what should I do? So having that communication and that support 24 hours a day can be really helpful. Maybe they can find a game on their phone to play. Certainly asking their partner for help would be really great. One NicheQ article about how to improve rooming in hospitals suggests adequate staffing as one strategy. And no doubt parents would benefit from more staffing in their homes at night too. It'd be great if we could arrange that at home. They might also take the opportunity to edit their pictures or binge watch TV, eat a snack. And hopefully you're familiar with Charlie's Kids. They're the ones that I believe have offered the board book about safe sleep. Sam Henke is the founder of Charlie's Kids, which is a nonprofit Foundation started in 2011 after his son died on his chest of SIDS. And their mission is to distribute information about SIDS and safe sleep practices to families. And he presented at Maine's AWAN conference in 2018, and I really appreciate how he took the recommendation to not bed share another step by offering actual achievable suggestions to address the reality of nighttime exhaustion, which is such a real thing. So it can be helpful motivation for some people to remember that there are unfortunate sleep-related deaths every year, and for some, that's all they need to do. For others, that they need other tips and suggestions besides that. So what if they're still not following safest sleep recommendations? What can you do then? So this is when you just kind of go back to asking yourself, what is my relationship with this person? How is my relationship? Does she trust me? Did I listen to her? Did I offer empathy? Do I truly understand her challenges? What else can they do to make their sleep environment safer? So what else can you suggest that maybe, okay, so this is what you're going to do. How about changing this up a little bit to make it safer? And how can you celebrate what they have done? Since there's a good possibility they are doing something safely, and recognizing that they're doing the best they can with the information and the support they have is great. So we can offer the information. The support is something we might have a little less control over. And remember that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. Here are some resources for families and providers. Of course, the Maine Safe Sleep website. I mentioned the National Institute of Child Health and Human Development Safe Sleep site. Great resources there for parents and healthcare providers. And AAP's Healthy Children website is a parent education website, has a lot of articles on baby sleep. And then there are some references here as well, and my contact info.
Great, thank you. So we are going to take questions, but we'll do that towards the end, actually. That way we have time to go through a few additional updates from Kelley and Alan. So I will share screen, and Kelley, I'm bringing up your slides next.
Great.
Great, thanks, Kayla. Kara, that was terrific as always. Thank you for all the research and the work you put into that. So I just want to make sure that people know where we stand with respect to hospital certification progress. And we are continuing to make really good progress. I'm really excited to announce that we have 18 hospitals in Maine that are now certified as safe sleep hospitals by the Cribs for Kids organization. There's another 2 who have submitted applications, and they are fine-tuning policies, and I anticipate that those 2 will be safe sleep certified in the next month. So we have a total of 20 that are either certified or well on their way in the process. We have 2 that are working on their policies, and we have 4 that I'm not sure where they are in the process. So we're getting really super close to having all birthing hospitals in the state as certified. If you're one of those hospitals that's not yet certified and you have questions, or there's something that I can do to support you, I'm happy to review your policy. If that's helpful, I have sample policies from other hospitals, happy to share those. Anything that'll help you get over that hump. I know that COVID threw a curveball at us from this perspective as well. So if it can help you get back on track with this, I'm happy to do that. So,
great, thank you. Now
I'll turn it back to
Alan.
All right, thank you, Kelley. Thank you, Kara. So I just wanted to really quickly, again, really truly thank everyone for all the work they've done over the past several months on submitting data. So in the words of Garth and who's the other guy on there? We are totally not worthy. So thank you all so much for all your work in the middle of the pandemic. Next slide. So again, just a quick little look on the audits to date. So in the bars, the blue bars, are the numbers of hospitals that actually had babies with infants. Now there's several hospitals that actually did report out to us that just didn't happen to have a baby on the day of the audit. And again, I just want a quick shout out to Down East Community Hospital. They won the quickest prize for the first submission of audit data in June. So thank you to Down East and thank you to all of you. So typically we hear from anywhere between 22 and 26 hospitals per month. So again, I hope it's a little bit of a distraction from COVID stuff to going out and doing safe sleep audits to date. So the total number of audits now, as you can see, we're approaching 400 audits since the beginning. So again, thank you all for all your work in quick data turnaround time to all of us. Next slide. So again, a little bit of a busy slide. So I just want to show, so these are each of the audit data pieces from the Cribs for Kids audit. So if I could take you to the left, the question asked, is the head of the bed flat? Again, we want that at 100%. As you can see, pretty consistent, close to 100%. The babies on their back to sleep, which is the second column, again, very consistently to 100%. The third, and we'll circle back on this in a little bit, of the multiple blankets in a crib. That's probably the one item that trips us up the most across the state. I want to point to stuffed animals or any other items in cribs. Initially, we were in the low 90%, and now we're at 100% in the last audit. Large fluffy blankets around the infants, usually in the 95% and above, that they don't have those in the crib. Is the infant in a positional nest? It's again a rare occurrence across Maine. Is a caregiver asleep with the baby? And so I really appreciate the honesty in the audits that people, found when they went to do the audits. They found a parent, and people have even been so wonderful about even writing in how they addressed it with the family at that time on the audit sheet. So again, I really do appreciate that. And then the last piece is positioning device. Is it used or not? And again, it's a fairly rare occurrence. So when you take each one of these, the question is, how many babies are in full overall compliance? All right, next slide. So again, going to show this back again, the multiple blankets in a crib. So when we did our first audit at the very beginning in February, it was about 70% of so about 30% of the time there were multiple blankets in the crib. Again, an incredible increase up through May, and then maybe a slight fallback in June itself. But again, it's something we're going to keep a close eye on, but there's been a huge improvement in this one item specifically. Next slide. When we look at the overall compliance, so that was the far right-hand side of the last slide, and this breaks it out over time. So basically, 57% of the babies were in full compliance in our February audit. It increased to, as you can see, 69%, and then 79%, then 83% in May, and with a little bit of regression in June. So again, I'm hoping that June is just a little bit of some data noise rather than a data signal, and I'm really excited to look forward to the continued great work in the July audit. Next slide. So overall, from February to June, we had a 33% improvement. So that's a pretty good boost, but knowing I think we can get higher, and I think our goal clearly should be 100%, but I think in the 90s would be wonderful to see. And then, so I always think about, elevator speech. So if you're in the elevator and someone asks you, how's it going? So a couple things we can remind people to say is that even with a recent dip from our overall high of 82% of full compliance, that we have increased up by a third since the beginning of the project. So that's really a good place to start out with. So even though we dipped from our high in May to June, what I want to point out is, of the 8 items on the Cribs for Kid audit, half of them were 100% compliance. We've never had that many at 100% compliance in one audit. So of the 15 hospitals that had infants that day that performed audits, that's pretty impressive. And so that I want to, even though we had a little dip in overall, I want to take some positive away from this. And then again, just knowing that multiple blankets in the crib, that's the audit item that most likely needs to be corrected at any given time. So if everyone could kind of go out and make a focus in their area, really specifically work hard and really talk about the multiple blankets. I know, speaking from our own facility, the issue happens to be a burp cloth, that it's an untucked burp cloth that sits under the baby's head. And that's been, again, something we've worked pretty hard. We haven't eliminated it yet, but we've definitely made some positive strides in that direction. And I think, yep, I think that's it for my slides.
Great.
So
now
Alan,
Go ahead.
sorry, Kayla, can I
No,
just
go
add
ahead.
one quick thing? Our next audit date is Tuesday, July 7th.
Yes.
So if you want to mark your calendars, it'll start nagging you on July 7th to get your audits done. And if you just do them, then I don't have to bug people. So thanks again to everybody that did audits. Thanks, Kayla.
Great. And we do have time for questions. So if people have questions, you can certainly enter it into either the chat or the Q&A feature, and we'll read those off to you. So let's see, the first question, it's kind of a question, it's a little bit of a comment. Is Kara available to do her safe sleep talk as part of a staff training for both providers and RNs?
I'd be happy to.
So to the person that just sent that, if you want to either get in touch with me or Kara after this, we can make sure you get to connected with her and we'll get that set up. Okay, they will get in touch with you, Kara, as I said. Other questions?
So not necessarily a question, but I think one of the things I picked up on was that Safe Sleep 7. And one of the mothers who thought she was achieving all of the 7, which was the baby on their back, she said herself that the baby was sleeping on his or her side, which wouldn't be considered safe sleep and wouldn't be one of the safe 7. So it just brings up this point about even when parents think they're adhering to safety recommendations, when you actually look at it objectively, they may not be.
Yeah, I wonder if she was nursing her baby, if that's the side sleeping she was referring to. But yeah, I think education on all areas are necessary, and giving as much information as we can and anticipatory guidance is great. And I'd love to hear from the people on this, like what do you say? What questions do you get from parents? What concerns do you hear? Love to have as much of a discussion here as we can with your own experiences.
Yeah, so people can definitely enter those into chat. And just to give you all a quick update, Alan had to drop off because I think he is on call. His phone kept going off. So Alan did have to drop off, but he thanked everyone for joining. But yeah, if you want to enter kind of any messaging you might use into chat, it's certainly helpful to share with others. So someone said you presented many of the questions in your presentation that they use, which is good. That's good to hear that feedback. Any other messaging or thoughts people might have that they want to share? You can certainly type into chat or the Q&A. I think there's also a feature where you can raise your hand, and I can give you permission to speak, I believe, on this webinar. So someone just said, or Jamie said, thank you for the tips on having a conversation with the patient and support person. I need to be better about having a conversation. So I think that's something a lot of people run into, and Kelley and Kara, I'm sure you both have heard those reflections before, especially in the day-to-day sometimes.
Yeah, I think campaigns generally need to be pretty simple, right? We can't get into too much nuance when it comes to visuals and in campaigns and materials sometimes. There might be some room for that, but it's really comes down to the conversation and how every person's going to have different needs and concerns and different babies. I think that's a big piece here. As I saw through the responses I got, some people had no problem, and maybe it was a lot of people referred to their individual baby.
I think the other piece, and I think Dr. Jennifer Heyman's on the call as well, and Sometimes when there's been an injury, a sleep-related injury, she talks with families, and some families continue to want to bed share, and so that becomes a harm reduction conversation. And Jen, do you want to unmute and maybe share some of your experiences?
Yeah, so I just added her. So Jen, you should be allowed to share now. She did type into chat too, but you should be able we should be able to hear you.
Hi, can you
Hi.
all hear me?
We can.
I heard, yeah, I was just finishing my chat when when you had me unmute. I think first, before I talk about the injury piece of things, I was just going to mention that I think the evolution of talking about safe sleep over the last decade has really shifted towards understanding the need to have those open-ended questions and honest conversations and sort of meeting the family where they're at. I think that's a key piece for finding common ground with families. In addition to that, I think we need to remember that as healthcare providers, we do have access to, the data and what best practices are. And ultimately, I do think it's important to share with families, what we know to be the best studied and what we know the quote unquote best recommendations to be. And I think you have the open-ended conversation. You talk about, well, here's quote unquote best practice. Where are you struggling with that? How can we then talk about risk mitigation? I do find sometimes my families get confused if I'm not clear about, well, what are the best recommendations? So I think it's important to, obviously talk about risk mitigation, but to also be clear as to what we think the best practices are. I think in terms of injuries while bed sharing, like Kelley mentioned, that's certainly something that we talk about, and that is a more underreported phenomenon than even death while bed sharing, because most babies who have an injury or a potential injury during bed sharing are not going to seek care. And there are studies showing that, parents are a little bit reticent to report when they've had a concern about a bed sharing injury or a near miss. So I think that those are also important things to talk about. And I think you have to balance. You don't want to, the tactic should not be to try to, scare parents into having the baby sleep separately. But again, it's sort of making sure that they understand what are the benefits of bed sharing and what are the benefits of separate but proximate sleeping as well.
Yeah, thank you. And Jamie had shared that, a concern she has is she's nervous about the liability coming back on her in the hospital and how to appropriately chart that conversation so that if a bad outcome does occur, the patient, wouldn't come back at them and said, the nurse told me I could bed share. So it's really that sensitivity, which I know Kara and Kelley, you probably face a lot around the conversation. And like you said, Kara, mitigating those risks. But do you have any thoughts around Jamie's concern about the liability piece?
Yeah, so I think in responding to Jen, I think we all are so thankful for the work that you do on a regular basis on this topic, and that, I wonder if it's possible too to give the evidence-based, I think it is possible to give the evidence-based information and also talk about, okay, so what if, and still having that hard line on these are the recommendations, this is what should be done. And I'm looking through the other comments and see Shani's comment as well about needing to strive for the top safe sleep practices versus talking about bed sharing safety. And so it's really it's one conversation when you're talking about prenatal education on the topic and postpartum and the hospital education on the topic. It does still have to be rather simple and like, this is what we recommend. And in the hospital, you might be getting to know those babies, and the ones that are just not settling on their own, that can be a good opportunity to say more about, okay, so these are the recommendations. It might not be easy. I think that piece is really important to talk with parents about, because as I mentioned And if they are expecting it to be easy, then it's going to be really, really extra hard for them in a way to see that, why is my baby not doing what my baby's supposed to be doing? And there can be a whole other list of challenges resulting from that mindset.
And that can be a good point. It can be about the timing of the conversation too. If somebody is coming back to a clinician after, going home with baby and really struggling and finding that they are falling asleep in some conditions that would lead to some unsafe sleep, it's kind of that risk mitigation conversation at that point.
Yeah, I think it's a different conversation at that point. And in terms of the liability piece, I think it all comes down to documentation again, right? And if you end up having a conversation where, this is a family that is saying they want a bed share, or they're having a really hard time, and you end up giving them some information to, some of that risk mitigation information, then documenting that that's what you shared, that you shared the evidence recommendations, you shared the safe sleep, for me, ABCs, ABCD, and that you may have also addressed their concerns or their questions with some other information that you felt was the safest information at that time.
Great. Thank you. I know it can be a hard topic to go around, and that's obviously why we want to discuss this topic today, because there is a lot of information to be shared and some wonderful resources, Kara, that you shared, especially with some prompting questions too. Okay, I think that might be all the questions we have for now. We're almost at the end of our time too, so I'll give folks one last minute if anyone has anything else they want to add into the chat. But otherwise, I'll go through the wrap-up slides while you have kind of another minute to enter anything into the chat. So I just want to make sure that you're all aware that we do have another Safe Sleep webinar coming up. It was a series of 3, so this will be the last one, and it's on August 18th. And Kelley and I were trying to remember what topic we had decided on, but I don't think we had talked about kind of some of the March to Dime stuff, but I don't think we fully settled on our final topic yet. So stay tuned; it'll be a surprise, and we'll make sure we communicate it out ahead of time. But definitely hold your calendar for August 18th from noon to 1.
And if people have suggestions, we'd love to hear those too.
And so somebody did enter, or Shannon entered into the chat, one of their major challenges is that parents are often feeling like they're getting conflicting information from nursing, leaving them confused. So she thinks it's also important to educate staff so we're delivering consistent information across the board. And I think everybody definitely agrees with that. It can be very confusing, especially for first-time parents that are getting a lot of new information too.
The other thing I'll add to that is that sometimes families assume, or I've heard people say, well, it's only the families that are drug affected, drug or alcohol affected, that their babies die from SIDS, or the smokers that die, their babies die from SIDS. And having done the chart audits with Dr. Heyman, we can tell you that that's not true. It's definitely a higher risk scenario, but there are definitely, out of the 10 to 12 babies that die in unsafe sleep circumstances every year, at least half of them do not have that risk of drugs and or alcohol exposure. So if people are asking you about that, that's what you can tell them. And again, it's about 10 to 12 babies per year in Maine die in unsafe sleep circumstances.
Well, thank you. And thank you, Kara and Kelley, for presenting today. And Alan, like I mentioned, had to drop off, but we'll thank him as well. It was great information, and everybody stay tuned for August 18th. I hope you all have a great